So the question is on the use of non-invasive mechanical ventilation in SARS coronavirus 2. This is Mazen Infectious Disease and Critical Care Medicine. Today is the 20th of March 2020. The problem with non-invasive mechanical ventilation that it is well-known procedure that can generate aerosols. Once these aerosols are generated, there will be an increased risk of transmission of the virus to healthcare workers. Thus, we need to do this procedure within a negative pressure room with all the personal protective equipment's been placed on, with the N95, the goggles, and the gowns with the gloves. And in this systematic review, Tran and his colleagues looked at different critical care procedures that can generate aerosols, and they looked at the risk of transmission of respiratory infections to healthcare workers, and they found that the highest risk is associated with tracheal intubation, where it is 6.6 times more than other procedures. Non-invasive mechanical ventilation was 3.1 times more. Tracheostomy was 4.2, and manual ventilation before intubation was almost 3 times. In the same paper, there are other procedures they found that they are not associated with statistical importance of increased risk. And then the question will be, will those patients benefit from non-invasive mechanical ventilation if we have to take the risk and protect ourselves at the same time? And in fact, the largest study available in the literature is from the Saudi Critical Care Trials Group led by Yassin Arabi, where they looked at non-invasive mechanical ventilation in critically ill patients with the Middle East respiratory syndrome that is caused also by coronavirus. And in their study, they looked at 105 patients who were on non-invasive mechanical ventilation, and this is compared to 179 patients who were directly intubated and put on invasive mechanical ventilation. The study was done in multiple centers in Saudi Arabia, in 14 different centers, and included total of 302 patients from September 2012 till October 2015. They looked at the SOFA score, and it was slightly different with statistical significance. It was 9 in the invasive mechanical ventilation versus 7 in non-invasive mechanical ventilation, and this is well understood. Those patients are sicker than the patients whom we decide to start on non-invasive mechanical ventilation. At the same time, the number of quadrants with infiltrates was 2 compared to 3 with statistical significance also. They found that the vast majority, about 92.4% of patients who were managed initially with non-invasive mechanical ventilation required intubation. So the majority of those patients ended up going into invasive mechanical ventilation, which will pose the question whether they would need to be on non-invasive mechanical ventilation in the beginning. When they looked at the mortality in patients with non-invasive mechanical ventilation, the ICU mortality was 64.8% versus 75.6% in invasive mechanical ventilation. The p-value was right on the border, 0.059. The ICU length of stay was not different between the two groups, and when they looked at mortality at 90-day mortality, they found that the use of non-invasive mechanical ventilation was not independently associated with 90-day mortality, with a p-value of 0.27. So the conclusion is that this procedure is a risky procedure to generate aerosols and increase the risk of COVID-19 transmission in ICU, and in majority of the cases, it did not help in patients who had coronavirus MERS syndrome. So the question is, should we do this or not? I think the conclusion from this study would be not to proceed with non-invasive mechanical ventilation, not to initiate non-invasive mechanical ventilation, but to proceed directly to invasive mechanical ventilation. And this is one of the correspondence that was just published in the Lancet Respiratory Medicine in February 24, 2020, and lists the recommendation that suggests that we need to move directly to invasive mechanical ventilation with intubation in those kind of cases. So I would say the use of non-invasive mechanical ventilation, or even the high-flow nasal cannula, which is probably similar to non-invasive mechanical ventilation, should be discouraged during COVID-19. There are other procedures that we need to make sure they happen when we intubate someone, because trachea intubation is associated with the highest risk of transmission. Number one, those patients should be in isolation room with a negative pressure or airborne infection control measures. Trachea intubation should be done by the most expert person in the hospital. We need to avoid bag mask ventilation as much as possible, and we need to make sure that we follow the rapid sequence induction with long-acting paralysis, so the patient doesn't start moving and coughing and then generate those aerosols. And also we need to make sure that we put the viral filter on the expiratory limb. This is all what I have today. Thank you very much. Appreciate your listening to this presentation.